been a pediatric nurse for 46 years and a pediatric nurse practitioner, although I'm a family nurse practitioner. And I've worked in the survivorship arena for the last 16 years. So I wanted to start out by just doing a little overview about survivorship and what is the definition. And if you look at different sites, you might get a little bit of a different definition. But the National Coalition of Cancer Survivors in 1996 that said that survivorship is from the time of its discovery and for the balance of life in an individual diagnosed with cancer. And not only is it the patient or the identified person with cancer that is a survivor, it also includes their family members, friends, and caregivers. So a little bit about facts. There are projected to be 1.9 million people diagnosed with cancer this year. Less than 1% of them are children. Approximately 11,000 children between the ages of 0 and 14, and approximately 90,000 between the ages of 15 to 39. And we classify that age group as the adolescent young adult or AYA group. So as you can see, I'm not sure what happened. As you can see, where the slides go.
Yeah, we're not seeing your screen, Karla.
You're not.
No, so let's just try again. If you go to the bottom, there's the share screen, the green button.
Right, hang on, let me minimize this. I did it, and it's share screen, share. Now did it come up?
There we go. Thank you.
Sorry, I couldn't tell on my end it wasn't shared. I apologize. No So the median age for a person to be diagnosed with cancer is actually 66 years. So that basically means 50% of the people diagnosed are under that age and 50% are higher. But the average age for a child is actually 6 years, although you have newborns that are diagnosed with cancer. And we know that cancer diagnoses have increased by 30% since 1973. But since 1991, cancer deaths have decreased by 31%. And that's the statistics presented by the American Cancer Society this year. What happened to cancer care? Well, 25 years ago, we didn't have things like biomarkers, or we had very few biomarkers. Cancer was primarily treated based on the histology, so what the tumor looked like under the microscope, the location of the tumor, and the size of the tumor when you're talking about a solid tumor. There were approximately 250 less treatment options available 25 years ago than what we have now. And back then, we had three basic ways of treating cancer: surgery, radiation, and chemotherapy. And we also had limited supportive care options, things we could do that could make the cancer treatment go more smoothly, people be more comfortable. And because I've been in this field since 1975, I like to say I grew up in the days that we didn't have good sedation procedures for doing painful procedures like bone marrows and spinal taps. We didn't have good anti-nausea medicine. We didn't have that until the late 1980s. So a lot of things have come around in the last several decades. And then since the 1970s, we've had a variety of new treatments. We have new therapies, but not even related to new therapies. We have better technology for doing imaging, CT scans, MRI scans, PET scans. And these innovations have improved surgery options. We also have precision medicine. We have ways of really being able to hone the treatment to be very specific for the individual patient. And we have immunotherapy, and many patients who are being treated today are receiving some form of immunotherapy as part of their therapy, if not all of their therapy. We also have things related to prevention. What are things we can do to prevent cancers from occurring? What do we know about genes? What genes make you more susceptible? What are things we could do with drug and surgical risk reduction and things that can allow us to hopefully keep cancer from occurring. We have a lot of things that can improve quality of life. As I mentioned before, we have better anti-nausea drugs. We have better pain management. We have less intensive therapies for many cancers. One of the things that we've seen in pediatrics, for some types of cancers, I'll give you an example of something called a Wilms tumor, which is a cancer of the kidney in young children. At one point, the children that had high-stage Wilms tumor got 2 years of therapy. Now, therapy is usually 6 months to a year. And then we also have improved palliative care integration, where we involve supportive care from day one. And then survivorship. It's really a growing area of research. We've identified a lot of potential late effects. And we have a lot of surveillance strategies that have been developed and are actually well established and are considered to be the standard of care for evaluating survivors. And then just to give you an idea of how cancer survivors are growing in numbers and living longer, in 1975, there were about 3.5 million cancer survivors. In 2019, there are about 16.9 million cancer survivors, and it is projected by 2040, there will be over 26 million cancer survivors. And these cancer survivors are all ages. So basically, 74% of cancer survivors now are greater than 5 years from their treatment. And that has tripled since 1971, and cancer survivors are growing up by 2% per year. And if you look at cancer survivors by age, approximately 2/3 of them are over 65, and a little more than 1/3 are less than 65 age. And so why are we concerned about cancer survivorship and late effects of treatment? Well, Dr. Kevin Offinger is actually a family practice doctor who has worked in the survivorship community for many, many years. And he sees child and adolescent and young adult cancer survivors. And he once said that the cancer experience is a process that extends throughout a lifetime. It's a looking glass through which all future health and illness behaviors of the survivor must be interpreted. And I think that's really important, that people always have to give information about their past history in order to improve their current health care. There were several books, particularly around 2005, a big emphasis came on survivorship, although the very first publication that I'd ever seen on survivorship came out in 1979, and it was a book written by a psychologist called The Sword of Damocles. And basically what the premise of this book was is, it's like that sword hanging by a thread. You don't know what's going to happen or if that thread's going to break, and really emphasize the importance of looking at issues that a survivor might have. In 2005 is when the Institute of Medicine came out with their report called Lost in Transition. And basically what they said is that survivorship care was critical to long-term health care. And it outlined 10 recommendations that specifically were aimed at enhancing the care of survivorship. And I'm not going to go over all 10, but I'm going to mention probably the 3 that I think are most critical. Survivorship is a distinct phase of cancer care. And it's important that patients have comprehensive care summaries and have a clear and effective follow-up plan. And that healthcare providers really need to develop evidence-based practice guidelines and develop assessment tools and screening that can help to identify and manage late effects. And that's what a lot of programs really focus on, is what can we do to enhance the quality of life and educate survivors about their survivorship care. So what is a late effect? In pediatrics, we define a late effect as any health complication that either persists or arises following the completion of cancer treatment. That problem can influence the survivor's quality and/or quantity of life. And the risk of developing health problems are really dependent upon the gender of the person, the age at the time of treatment, and what the current age is. What specific treatments and what were the doses of those treatments? What was the intensity of therapy? And then what was the psychological support that patients received during their cancer journey and their treatment journey? And then what are their other health conditions? Do they have comorbidities? What are their current health conditions? What's their diet like? What's exercise like? Are people smoking? Are they drinking alcohol? Are they using illicit drugs, et cetera? But we do know that many long-term survivors will develop one or more long-term healthcare problems. And unfortunately, in the general medical community, these problems may be underappreciated or not recognized. And we also know if you do develop a late effect, it's important to catch problems early because they are more easily treated if they are caught early. So what are some of the burdens of survivorship? Physical, and many of you who are cancer survivors have experienced things like fatigue. Some people have some organ disease that may have developed, maybe kidney disease from one of the therapies, maybe heart problems from a therapy, and endocrinopathies, hormone issues. Many of those related to thyroid, but also related to sexual function. What are possibly post-surgical changes? Somebody who's had a mastectomy or somebody's had an amputation. And then what about cancer recurrences or second cancers developing? From an emotional point of view, many people have a fear of recurrence. Sometimes there's social isolation. There can be relationship problems among peers, around your partners, romantic liaisons, family members. One of the things we often see in kids, and I would assume this is the same in the adult world, is when someone's newly diagnosed, everybody rallies around, but as time goes on, you get less of that support as people go on with their normal lives. One of the psychologists that I used to work with, though, talked about cancer survivors getting stuck, meaning they didn't move forward with their life. They were kind of, she equated it to being almost like on a treadmill. You just kept running in place. And we certainly know that psychosocial distress occurs actually not only in survivors, but often the family members, caregivers, parents of cancer survivors. And it can either be a post-traumatic stress syndrome or it can be post-traumatic stress disorder. There can be social issues, particularly related to things like insurance. Prior to the Affordable Health Care Act in 2010, you might not be able to get health insurance if you had had a cancer diagnosis because many insurances penalized you for having what they considered a pre-existing condition, no matter how long you had been off therapy. Many cancer survivors don't qualify for life insurance, and that might be important for a family because it's a way of providing financial resources to family members. Many people have issues with school or work performance. One of my patients several years ago happened to be a school teacher. He had a master's degree, was a very bright guy, and he ended up having some brain fog and a slowing of speed of processing. And he would get very frustrated saying, I know this, but I can't seem to get it out. Or it takes me so long to get from point A to point B. And it made him feel very frustrated because he felt that he wasn't being as good of a teacher as that he had been prior to his cancer diagnosis. We also know there can be a huge impact on family members and some issues related to caregiver burden. And that's a real issue, no matter how old the patient is and no matter what type of support they have. And then some patients have spiritual issues. And why is it me? Why did God do this? I'm a good person. Why did this happen to me? And a lot of questions that can't be answered, but can either give you a good sense of meaning of life, but it also could make you feel very distressed, feeling that you haven't lived up to expectations. So what are some of the potential problems? There can be issues related to growth and development, particularly in children who haven't achieved their full skeletal growth. There can be issues related to intellectual function, emotional and social maturation. There can be issues related to organ function, primarily heart, lungs, kidneys, the endocrine system, GI issues, and issues related to vision and hearing, because many of the treatments can impact one or more of these areas. There can also be issues related to fertility and reproduction. Have you lost your fertility? And there are often concerns about the health of the offspring. The good news is that we know, other than some very specific circumstances, the offspring of cancer survivors have no greater risk of developing cancer than anyone in the general population. And then there can be the issue of second tumors, whether they are benign or malignant. And all of these really impact what we call the health-related quality of life for a survivor. And Dr. Julie Rowland, who was the director of the National Cancer Institute for the Office of Survivorship, said being cancer-free is not the same as being free of cancer. And late effects are really the price that was paid for the cure and the quality of life that was purchased. And I can tell you, as a clinician who has been in the field since the mid-1970s, in the 1970s, all we cared about was trying to get people to survive. Now that focus has changed. Of course, we want survival, but now we want to have survival where we cure people well. We want to have the least amount of therapy to have the greatest cure with the least amount of side effects. So one of the ways that we feel that we can help take care of people after they had completed their active cancer treatment is something called cancer survivorship care plans. And what are they? Well, it's a summary of your cancer treatment, the therapy that you received, any significant complications, and it really needs to be something that is used by the survivor, the oncology team, and the primary healthcare providers. It's important to use a care plan to coordinate care and surveillance of health, to give information about what is appropriate health monitoring and health promotion, and also improve communication among the healthcare providers as well as the patient and family. Also, it helps us to identify and manage long-term sequelae. Helps us to know when to refer to an appropriate specialist. And it might be a school person, it might be voc rehab, it might be to a medical specialist. It's whoever is going to be the best fit to help the person with the identified problem. So they're really an aid to help ongoing care for a survivor. They're tailored for the specific treatment exposure and risk factors that you might have. So for example, if you did not have therapy that has the potential to impact your heart, you don't need any different type of heart screening than you would need for the general population. But if you did have chemotherapy, such as doxorubicin that can affect your heart, or you had radiation to your chest that can affect your heart, well, your screenings for healthcare are going to be different because of those treatments than it would be for the general population. And an example of that is if we have women who had chest radiation, regardless of the age they received the chest radiation, whether it be as a young child, whether it be as an adolescent, whether it be as a young adult. If you've had radiation to your chest, normally we look at breast cancer screening starting at age 40. Well, in someone who's had radiation, we now start breast cancer screening at either age 25 or 8 years after the treatment, whichever occurs last. So if we had a 15-year-old who had chest radiation, she will start breast cancer screening at age 25. If we have a 20-year-old who had chest radiation, we would start breast cancer screening at age 28. And we also then want to do those referrals to the appropriate specialist if a problem is identified. And it's very important that survivorship care include health promotion. And it should be age and gender appropriate. And it should include normal routine cancer screenings that you would do for the general population. They might be modified because of your cancer treatment. But again, if you didn't have a cancer treatment that affects a certain area of your body, then that screening would be done at whatever is considered the appropriate age for a screening to occur. The United States Preventive Task Force is who develops and publishes the recommendations for screenings. And in the last couple of years, they changed colon cancer screening to start at age 45 instead of age 50. And so that's the recommendation for the general population, is that for colon cancer screening at age 45. If you had cancer treatment that included radiation therapy to your GI tract, that colon cancer screening is going to start at age 30. So there are times that a treatment is going to modify those normal screening practices based on the treatment that you have received. ASCO, which is the American Society of Clinical Oncology, has now started to develop a standardized method of care plans and strategies to help with cancer survivorship care in adults. And they have developed some resources out there to help with people with their survivorship. One of the major areas of survivorship care has been developed by the Children's Oncology Group. In fact, the Children's Oncology Group is the first medical group that developed survivorship care. And many of the adult groups are now modeling after the childhood cancer group. And the main purpose is to develop both research and evidence-based practice of how to care for survivors. So treatment summaries are critical. Patients need to have a nice, concise summary of where they were treated, what their treatment was, what their basic diagnostic and staging information was, what age they were treated, what was their chemotherapy, did they have biologic response modifiers, did they have radiation, what surgery, did they have any significant toxicities during treatment. Tomorrow, I'm seeing a patient who had a bone tumor, but she developed some very significant pulmonary problems during her treatment. And although her treatment itself did not impact her lungs, that infection did impact her lungs. And now we know that because of that, we need to also screen for toxicities related to her pulmonary function because of that complication that she had during treatment. And so it's important that patients have a written summary. This is one patient's stack of charts before we were lucky enough to have electronic medical records. And so to do a summary, it's a matter of the healthcare provider digging through those charts to come up with what's important for the patient to know and have. It's not going to be of any value to send that entire medical record to another provider because no one's going to look for it. But if you're in survivorship care, a summary that's usually anywhere from 1 to 3 pages long can be pulled from those records and did you have radiation? If so, what was the dose and field? If you had chemo, what were the cumulative doses? And did you have standard dose chemo or high dose chemo? Did you have surgery? What type of surgery? Did you have a transplant? What type of transplant? Did you have graft versus host disease? Did you have other cancer treatments? What complications? When did your therapy complete? It's also nice to have the name of the treatment facility and potentially the team members who treated you if that's possible. So the Children's Oncology Group has very specific guidelines, and we also have patient education that's part of our recommendations for survivorship care. And those guidelines are called health links, and they specifically talk about issues related to a potential toxicity you can have from a specific treatment. These are available at survivorshipguidelines.org. It is a public site. Anyone can look up this information and pull the health links and pull the guidelines for looking at how you should be screened. And this is just what our website looks like. And again, the website. These guidelines are actually renewed every 5 years. The latest one is 2018. So 2023 will bring out the next edition. And then the National Comprehensive Cancer Network also now has guidelines on survivorship. And so again, it's looking at what are the things that impact an adult cancer survivor? What's the physical and mental health? What are health behaviors? What are professional and personal identities and your sexuality? Also issues related to finance. As anybody knows who's had any type of catastrophic illness, that has a significant impact on your financial well-being. potentially. And then these NCCN guidelines were developed in conjunction with the National Coalition of Cancer Survivors. The ASCO guidelines have clinical guidance. They provide mottos for survivorship care. They have provider education as well as education for survivors and family. They're trying to do everything based on research. And there's also information regarding policy and advocacy. So what do patients need to know? So one of the things is, where are you going to get your survivorship care? In pediatrics, kids who are treated in children's hospitals typically age out when they turn 21, because that's how old patients are when they're in pediatrics, as 21 and under. So where are you going to get your care? If you're an adult, you might be moving because of a job or whatever. So knowing where to get your care. And one of the things that we try to do is, anytime someone lets us know that they're going to relocate, we like to hook them up to a survivorship program in their new community. Some institution, the primary healthcare team that provided the oncology care, will provide the late effects, but in many institutions, at least in pediatrics, we now have designated specific survivorship programs where the providers in the program are only seeing survivors. And then we also need to know, what does your insurance allow? And that's going to be something that's really important for people as they get out into the workforce. If you're changing jobs, how do you choose an insurance plan? Sometimes choosing the plan that is the least expensive on a monthly premium basis may not be the best choice if you have a lot of medications or you need physical therapy or whatever. So those are also important things to consider in developing your follow-up care. And one of the things that is really important is make sure all your healthcare professionals know about specialized follow-up needs. And that includes people like your eye doctor and your dentist. Certain treatments make you at greater risk for things like cataracts. Certain treatments make you at greater risk for having dental issues. So it's really important that all those healthcare providers know your past history and treatment. Some of the things we consider the absolute must are that you should know the name of the disease you have, know the treatment, and make sure you get a written summary. And knowing the details of your medical treatment can really help you get the best care possible. It's important to have a primary health care provider. And that provider should have a copy of your treatment record. In fact, when we give our patients their survivorship notebook, which I'll show you a little bit in a few minutes, we encourage them to give a copy to their healthcare provider so that they have a reference. And we also, for example, our clinical notes from when we see the patient, we put the information in for the healthcare provider. What are things the patient needs to have done and why they need to have these things done? You know, a lot of insurances, if you try to schedule a mammogram on a 25-year-old, they'll say, well, they're not of the right age, and they'll deny it. So we have to have the rationale as to why something is needed, especially when it's outside what's considered the normal age range. Many patients follow up with their oncologist regularly, but it depends on how far out from treatment, and different programs have different recommendations for how long you follow up with your primary oncologist. Currently, most long-term follow-up programs are recommending annual follow-up. And now one of the silver linings of COVID, it really has opened up telehealth. And in our program, we're looking at patients who don't have significant problems, maybe every other year, seeing them by telehealth versus an in-person visit. It's important that you see a medical specialist if needed. If you have an endocrine disorder that was caused by your cancer treatment, you're going to be better off being followed by an endocrinologist versus a primary care physician, because the endocrinologist is going to have more expertise in those hormonal issues. And as I mentioned before, it's also important that the dentists know. And part of our program is we spend a lot of time focusing on health education. What are healthy lifestyle habits? What are the benefits of good nutrition and exercise? How do you decrease stress? How do you increase feelings of well-being? How do you promote your health of your tissues and organs? What can you do to reduce the risk of certain cancers and other diseases such as heart disease? It's important to have regular well checkups. I have to be honest, I can't tell you the number of my patients who don't get a primary care provider saying, well, I come to see you every year. Why do I have to see anyone else? Well, in the survivorship world, we provide care related to survivorship. We're not the person to call if you have a viral infection or have some other type of problem, and you really need to have a good relationship with a primary care provider. You need to make sure you're up to date on immunizations. We really focus on trying to have people maintain a healthy weight. General lifestyle behaviors: use sunscreen, wear hats when you're out in the sun, wear seatbelts, have safe sexual practices, exercise regularly. If you drink alcohol, drink in moderation. If you are on a medication or you have a health problem that alcohol can interfere with, then you would not want to be drinking alcohol, and you should know that information. Don't use tobacco in any form or use recreational drugs. For kids who are school age, we often use a school reintegration specialist to help them get back into school and also help them if they're having problems with school. Neuropsych testing can be done to assess how you learn and what are your strengths and weaknesses. And this can be helpful for not just kids in school, but for someone who's in the work environment. If you're struggling with some of your tasks at work, it might be helpful to have a neuropsych evaluation so that you can learn what are your strengths when you are learning and processing, and what are your weaknesses. How can you use your strengths to improve your day-to-day function? And then we also encourage patients to look, what are you eligible for financial assistance for education or for job training? And we really try to teach patients to be their own advocate, learn how to be an advocate. And it's important that you consider yourself to be a partner with all your healthcare providers. We want patients, again, to learn about the treatment they receive, get those regular checkups, work with your healthcare provider, and make healthy choices. And remember, when you're talking about the healthcare team, you are the most important part of the team. If it weren't for you, you wouldn't need that team. And so you need to consider yourself a team member. And I'm going to give you a little information about our program. In our program, we see patients who are diagnosed with a pediatric cancer or cancer-like illness at less than 40 years of age. But they have to have an illness such as leukemia or lymphoma, et cetera. We don't see patients who are diagnosed with primary colon cancer or primary breast cancer as a 25-year-old. But we do see patients who are diagnosed with tumors that are considered to be pediatric tumors. People need to be in remission and off therapy for at least 2 years. And we have no upper age limit for the survivor who meets the above criteria to come to our program. In fact, I actually have 2 patients who are older than me. One was treated in 1950 and the other one was treated in 1954. And so they are very long-term cancer survivors. In our program, it's what we consider a nurse practitioner-led program, but it's very much a collaborative team approach. We currently are grant funded, so there's no billing to a patient or to their insurance. And we screen you with tests that are specific to the treatment that you had. Patients do not have to have been treated at City of Hope. There are many survivorship programs that only see patients who are treated at their institution. Patients can be referred by a primary treatment team. They can be self-referrals, or they can be referrals from other institutions, particularly when a patient relocates. So as I mentioned, we're a clinical research program. All patients do have to sign a consent to participate. We collect clinical data, we do clinical exams, we get family history, we do diagnostic evaluations, et cetera. We identify if there are any late effects that occur. We do get self-reported data from the patient. What are their social demographics? What's their health knowledge? What are their health concerns? And what's their current quality of life? We developed a summary prior to the patient coming and and based on the COG guidelines, we set up all of the appointments needed for screening, whether it be, an echocardiogram or a chest X-ray or an EKG or whatever is specific, what specific labs they need. So at the first visit, they sign a consent, or if sometimes they sign a consent prior, because we now have electronic component for consent signing. They will be seen by either a nurse practitioner or a physician. They'll be seen by a psychologist and a dietitian. And we do that ancillary testing, as I mentioned. And then we see them annually. And what we do for future screenings are based again on the Children's Oncology Group guidelines. For example, an echocardiogram might need to be done every 2 or 5 years, depending upon your specific treatment. We do give patients a notebook, and in the notebook, we include a sheet that has all of the members of the team and a little bit of information about each team member and our contact information. We provide them with recommendations based on what are you at risk for, and what things do you need to do. And we have this information in Spanish as well. We provide the appropriate health link based on their treatment exposure. We also provide them general information about health. How do you have improved cardiac health? What do you need to know about immunizations, and what immunizations should you be having? Should you have had some immunizations repeated after you've completed your cancer treatment, because did your cancer treatment wipe out your immunity? So all of that type of information is included in their notebook. We do a follow-up letter to the patient or the parent in our situation when we have children that are underage. We give test results in lay language. We do call them to go over any test results that were not completed at the time of their clinic visit. We will provide a letter to their primary healthcare provider and or their oncologist and refer them to a specialist as needed. Our team reviews patients to make sure that nothing is missed, that we're looking at the patient and providing the best possible care. And we do enter information that we find into a research database. And that information helps us learn more about how we can improve care to survivors. It is, as I said, a multidisciplinary team, and we really feel that by participating in survivorship, it can help empower a patient to know more about their health and their health needs. And many patients want to participate in clinical research because they feel it's a way of giving back to the community. We also provide a lot of information about resources. In the childhood cancer area, there are a lot of programs that have educational scholarships for childhood and AYA survivors. There are a lot of support organizations. Almost all of them have been started by cancer survivors, kind of as a grassroots effort to provide information for other survivors. So what's the impact of survivorship care? We know that cancer is often life-altering. It can be very traumatic, obviously, but the goal is to make recovery easier by educating a survivor, giving you ways to manage stress, teaching effective behavioral and coping skills, directing people to resources, because we not only want people to survive, but we want them to thrive after treatment. And so life is really hollow gift unless this cancer survivor emerges from treatment as both a competent and worthy individual, able to obtain insurance, earn a living, prepared to participate in medical surveillance programs, and to really keep the life they have won. I'll have patients who, especially kind of sometimes adolescents, who kind of want to ignore everything and develop some really reckless behavior. And I might say to them, wouldn't it be sad if you beat cancer, but you had lost your life because you did something stupid by going out binge drinking and then driving? So it's really important to help patients understand that having won the battle against cancer, they need to continue to improve on their life and take advantage of the opportunities that they have. And now I would like to open it if there are any questions or any specific things related to information that people might want.
Well, thank you so much, Karla. This was just such a well-rounded and comprehensive approach to looking at survivorship. So we really appreciate it. There are a few questions that came in the chat, so I'm going to read those off, and then I'll invite people to also unmute themselves if they want to ask questions. But somebody asked kind of a two-part question. First, are there any clinical studies for pelvic floor issues from radiation in survivorship? And then as a follow-up to that, is pelvic floor therapy offered at City of Hope?
And I'm going to have to defer a little bit. The answer to the first part is yes, there are some studies and information regarding that. It's not a huge issue in childhood cancer, so I don't have expertise in that area. And I do not know of what programs are available for those disorders at City of Hope. Doug might know. Do you have a better understanding or better knowledge than I have of what are some of the adult programs that are available at City of Hope?
I just posted a link. I'm not that familiar with them, but I knew that we did offer the pelvic floor therapy. So I looked it up after I saw that question and posted the link to the information.
Okay, thank you. I do know there are some physical therapists who specialize in pelvic floor difficulties and that can work very effectively with patients for kind of retraining your body and increasing, a lot of it I think is muscle strength, but I don't have familiarity with those cancers, so I'm not the best person to ask. I apologize for that.
And then another person asked me a little bit more specifically about fertility preservation methods during treatment, things to be aware of during survivorship for fertility.
Okay.
Fabulous question, and it's really an extremely important area. For more than 50 years, we've had the ability to do sperm banking. So any male who was an adolescent or above who had been through puberty had the potential to be able to bank sperm. Although if they were extremely ill at their presentation, by the time they were well enough to bank sperm, they may not have had viable sperm. Now, there's been so much research and ongoing research and so many developments in fertility. There are whole areas of specialists who only do fertility, either male fertility or female fertility. Female fertility has opened up dramatically in the last 2 decades. When we first started being able to have some degree of female fertility preservation, the only thing you could do was preserve or freeze an embryo. So if you have a 15-year-old girl, how many 15-year-old girls are going to have a partner that you want to make an embryo with? Do you want to, as a 15-year-old girl, want to get a sperm bank donor and have an embryo made? Well, now in the last at least decade or so, we can harvest ovarian tissue and then be able to not have to freeze embryos. We can freeze eggs. And so when a patient is ready to have a pregnancy, if they did lose their fertility, they have eggs or ovarian tissue in the bank. There's also things being done for males who are prepubertal at being able to harvest testicular tissue and even reimplant that tissue after they're done with their treatment and allow them to go through puberty. And Children's Hospital of Philadelphia is one of the leaders in some of that type of research. So there are a lot of options out there that weren't there before. When I see a adolescent or young adult female, we do look at obviously the treatment. There are some cancer treatments that don't impact fertility. There are other cancer treatments that significantly impact fertility, or for females, there are treatments that cause them to go into premature menopause, going into menopause at the time of your treatment and never coming out. Regaining your menstrual function and your cycles, and even having eggs available but all of a sudden you lose them at age 25 because you go into premature menopause. So we have identified the major culprits, and it's not just the agent, it's the cumulative dose of the agent. So when we do summaries, we look at, did you have therapy that puts you at risk for infertility? And did you have enough of that therapy to put you at risk for infertility? So when I see patients that are what I would consider to be moderate or high risk, although I do talk about fertility issues with patients of all risk factors, I really encourage my female patients to seek at least a one-time consultation with a female fertility expert, because they can now do things like high resolution ultrasounds and see how many eggs you have left in your ovaries. Females are born with all the eggs they will ever have. And when they're gone, they're gone. And when they're gone, that's menopause. So I have patients who are now in their late teens or early 20s, mid 20s. And when they see a fertility specialist, some of them have a huge amount of eggs, so nothing really needs to be done. But I have other patients that have a very small number of eggs. And if you don't harvest those eggs, by the time they're ready to start a family, those eggs might be gone. Then there are the ability, if a female who has gone through menopause, or we call it premature ovarian failure, that person, if you keep that uterus healthy, you can actually implant an embryo, a donor embryo in that person's uterus, and that person can carry a pregnancy. I've had a few patients that have done that, and I actually saw a patient last week. She has no eggs left at all. Her sister is actually going to be donating eggs. Her husband is going to, have those eggs fertilized, and when they are ready, that she will actually be able to carry the baby. And even though the egg is not from her, the embryo will be implanted in her, and she will have a pregnancy and be able to have hopefully a healthy child. And so a lot of that technology, it's really amazing and it's revolutionary. And it's been a very, very big focus over, I'd say, the last 2 decades in particular. There are some issues with it. Health insurance may not cover it or may not cover it very well. So that's one of the things I talk to patients about when you're looking for health insurance. Look at what they cover and what your needs are going to be. And then try to choose a plan that's going to best meet your needs. There are some really good resources to help with health insurance. Triage Cancer, that I have listed on the screen, they are a nonprofit that helps patients really navigate the insurance and healthcare world, figuring out how do you know what is a good plan for you? How do you know how to make decisions, et cetera? I know. Did I answer your question, whoever asked the fertility question?
Well, I think that was great. And I mean, it's so encouraging to hear about the technology that's available now. That I know one of my dear friends is a childhood cancer survivor, and those options weren't available to her necessarily 15 years